Hello everybody, and thank you for joining us today. Today I will like to present to you my first result with a new porcine acellular dermal matrix, the NovoMatrix by BioHorizons. I'm a dental clinician who works together with 4 other colleagues in a team of 32 people nearby Dortmund, and I want also introduce to you Professor Dr. Werner Götz, and I'm going to show to you some very beautiful histological pictures which have been prepared by Professor Dr. Werner Götz. He's head of the oral biology laboratory at the Department of Orthodontics at the Dental Hospital of the University of Bonn. Dear Professor, thank you very much. Although our main topic for today is the soft tissue management, I would like to give you a short summary about biomaterials for the hard tissue management, because these two topics go together so closely. I would like to start with a little prologue. Wouldn't it be perfect if we could offer our patients evidence-based workflows for nearly every kind of tissue management as an alternative to autologous tissue harvesting, like in this case? This case probably belongs to the least demanding procedures, a simple and very predictable ridge preservation. One will find an appropriate ridge after utilization of, for example, a porcine bone substitute material in combination with a slowly resorbing collagen membrane. In my daily practice, I often need to gain some time, for example, to care for insurance issues. In these cases where I do not perform an immediate implant placement, I love this combination. The histological results are very predictable. And clinically, I compare it with a penalty shot. But when it comes to cases like this one, where we have to face a lack of hard and soft tissue, therapy becomes a little more demanding. This is a pre-op CBCT, and you can see that we have a good vertical bone availability, but we needed to gain some bone in the horizontal aspect too. In this case, I utilized a bovine bone substitute material with a slow resorbable bovine collagen membrane in order to maintain a long, stable result. This was a very fast and patient-friendly procedure. But in order to thicken the thin soft tissues, I grafted a subepithelial connective tissue graft from the palate, which worked fine for me, and it led to stable results, but my patients were often complaining about the palatal discomfort. In Germany, it is more difficult to work with allogenic dermal grafts as it is in the United States, for example. I knew the studies for the allogenic alloderm by Allergan, and I was very happy when I was asked to utilize the new porcine NovoMatrix, which is going to be distributed by BioHorizons. I thought maybe it is a light at the end of the tunnel for those patients who deny palatal harvesting. At this point, I would like to take a closer look at the hard tissue management. A very helpful fact sheet was written by the EDI, and it is called the Cologne classification of alveolar ridge defects. As you can see, it is divided into 2 parts: inside the alveolar ridge geometry and outside the alveolar ridge geometry. Especially inside the contour, and based on the premise of adding autogenous bone plus long-term space-maintaining membranes, we can reduce the invasiveness of our surgery by utilizing biomaterials. The least restrictions are suggested for sinus lifting, so I would like to start with that part. First of all, the classical lateral window approach. Rakebeur and co-workers showed in a review which was published in 2018 that implant survival is high. No differences between autologous bone or bone substitute materials could be shown. In this video, you can see the utilization of osteotomes, also a very classical technique which was described by R.B. Summers in 1993 first. Peterson and Lang pointed out in 2014 that it is still controversial if it is necessary to add bone or bone substitute materials in combination with this technique. But when it comes to procedures in which the elevation of the Schneiderian membrane is higher than 2 to 3 millimeters, it might be useful to utilize bone or bone substitutes, or at least space-making materials. Concerning the literature about the alveolar ridge augmentation, I would like to cite a review of Alnavas and Schignitz, which was published in 2014. Within the limitations of this meta-analytical review, implant survival seems not to differ between the group of autologous bone and bone substitute materials. At the end of this part, I would like to show to you some of the beautiful pictures which Professor Goetz has made. In these pictures you can see the mineros granules, which are surrounded by a new bone formation. In this slide, I like to ask you to focus on the arrows, where you can see osteoclasts, which are degrading the mineros granules. And in the third picture, Professor Goetz utilized a special staining, which is capable of showing the activity of the osteoclasts while degrading the granules. I love those pictures. The next short topic is about hard tissue management in more demanding situations. We have already talked about the Cologne classification, where it was recommended to add autologous bone and use special membranes when it comes to larger defects. The classical sites of harvesting bone are, among others, the angle of the lower jaw, the chin, and the cheekbone. But sometimes the local bone is more than enough when the bone is mixed with biomaterials. Even by smoothing the ridge or leveling the ridge, we often gain enough bone for grafting, especially in the combination with biomaterials in the right indication. For those who like to work with rotating devices, it might be recommendable to work with an ACM, which stands for Autologous Chip Maker, which is a simple and fast technique. Whenever it comes to extractions, I try to utilize a dentin, which can also be mixed with biomaterials in order to achieve larger volumes of bone substitutes. This is a picture of a dentin granule, which is embedded in a new bone formation. When it comes to larger defects, I also love to combine biomaterials with autologous blood concentrates. Blood concentrates can be helpful to stabilize bone substitute materials and have a positive influence on wound healing, especially on the soft tissue healing. When someone is not used to draw blood on a regular basis, a so-called vein light can help to identify the veins in order to place a butterfly, or, what is my personal favorite, a small and soft intravenous catheter, as you can see right now. It allows to draw blood very quickly. The blood concentrates can be helpful to stick the granules together, as you can see here. When it comes to very little perforations of the Schneiderian membrane, or when someone likes to protect the membrane for a short period of time, blood concentrate membranes can be combined with classical collagen membranes. The bone granules, which I had utilized in this case, were large granules of the porcine minerals XP, which led to a lot of room for new bone formations. In order to avoid micro movements of the biomaterial granules, it can be recommendable to stabilize them by utilizing stabilization aids, which can be seen as a kind of breakwater protecting the granules. There are classical Curie shell techniques, as well as metal plates, which can be screwed to the jaw, or the so-called umbrella technique with tenting abutments and tenting screws by Marco Schlee. At this point, I would like to conclude the item of bone augmentation with the following recommendations. Horizontal augmentation is easier than vertical or combined augmentation. Outside the contour is much more demanding than inside the contour. Blood concentrates or dentin can be a valuable addition. Thank you so much for staying with me so far. We are now heading for the summit. Our next topic is the soft tissue management, and I am going to focus on acellular dermal matrices like the NovoMatrix. Most of us agree that autologous soft tissue is still the gold standard in many soft tissue procedures, but they often result in discomfort at the donor site, thus leading to a limited patient's acceptance. Nearly 15 years ago, Griffin and co-workers could already show that the utilization of dermal matrices can be helpful to avoid adverse events like bleeding and swelling. And also Vessels and Tatakis have shown that patients do experience significant pain at the donor site. Another issue which we have to deal with when we are utilizing subepithelial connective tissue grafts is that we are often have to face a different texture and a certain kind of discoloration of the tissue due to the different keratinization of the palate and the buccal mucosa. Stefanini, Randon, and Zucchelli published a case series lately and showed that the utilization of dermal matrices can lead to high aesthetic outcomes at single implant sites. At this point, I would like to differentiate between processed, resorbable, and often porous membranes, which are constituted by the manufacturers, and acellular dermal matrices, which are of natural origin, except the fact that all the cells and skin appendages like hairs and glands have been removed, thus leading to a dense and natural structure. In generally speaking, the dermal matrices are taken from the dermis, which lies in between the epidermis and the subcutis. In this picture, you can see a histological examination of the NovoMatrix. I trimmed the matrix in order to transplant it, and Professor Götz examined the residual part of it. The origin of the NovoMatrix is the porcine dermis. After this matrix has been processed to become acellular in order to avoid immunogenic reactions, you will still find vascular channels, collagen type 6, elastin, fibronectin, and proteoglycan. When you take a closer look at these pictures, you can see a very dense collagen structure. On the left side, the residual tissue of an artery, and on the right side, the residual tissues of a vessel which was embedded in a fat tissue. These structures can be seen as a conductive guide for the consecutive remodeling of the soft tissue. In this slide, you can see on the left-hand side a punch biopsy of a patient who was treated with the NovoMatrix 8 weeks before. And on the opposite side, a picture of a punch biopsy of a natural keratinized soft tissue from the alveolar ridge of another patient without transplantation. We found a very natural appearing tissue formation. The most documented indication for soft tissue management is the recession coverage. I would like to start with the consensus recommendations of the 10th European Workshop on Periodontology. Nearly 80% of recessions get worse over time and can lead to sensitivity, cervical lesions, root caries, aesthetic problems, and inadequate plaque control. It had been pointed out that due to discomfort issues and the limited amount of natural donor tissue from the palate, it might be helpful to find substitutes for autologous tissues. Furthermore, the American Academy of Periodontology stated 1 year later, although subepithelial connective tissue grafts must still be seen as the gold standard, dermal matrices or enamel matrix derivatives can be used as an alternative. Let us take a deeper look at the latest reviews. The following conclusions have been made by Cambrone and co-workers, exactly like the AAP. They pointed out that autogenous subepithelial connective tissue graft can still be considered as the gold standard. Subepithelial connective tissue grafts in conjunction with coronally advanced flaps are superior to processed collagen matrices, but the utilization of dermal matrices lead nearly to similar results in the gain of keratinized tissue width and gingival recession reduction. The incidence of adverse effects, for example pain, was mainly related to the donor sites of the subepithelial connective tissue grafts. Further indications for soft tissue management are, for example, rich contour augmentation, especially in aesthetically demanding situations with pontics, or to modify the dimensions around teeth, like in this case before orthodontic treatment. I would like to take a deeper look at the indication of modifying dimensions around implants. I picked out 3 papers which were very important for me. The first one is a narrative review which was published by Christoph Hämmerle and Dennis Tano in 2018. It could be shown that soft tissue sickness is one of the factors which can lead to hard and soft tissue deficiencies at dental implant sites. The second paper was published by Thomas Linkevicius and co-authors in 2018 too. It is about the findings of a prospective clinical trial about vertical soft tissue sickness on bone stability. Patients were divided into 3 groups depending on the thickness of the soft tissue at the implant sites. A thickness of 3 mm or more millimeters led to significant less bone loss than it was found in the groups of 2.5 mm or 2 and less millimeters. The third study, which I like to cite, was published by Monica Puzzo and co-workers lately. They found out that the probable threshold for soft tissue thickness in order to prevent bone loss around implant sites could be seen at 2.88 millimeters. which goes into the same direction as Thomas Linkevitz's findings. What are the prerequisites for a successful augmentation with an acellular dermal matrix? In my opinion, it is mandatory to work with an adequate microsurgical instrumentation. The matrix should be fixed to the underlying tissue so that no micromovements can occur. I would recommend to cover the acellular dermal matrix graft completely. And at this point, it's again time for a take-home message. Subepithelial connective tissue grafts can still be seen as the gold standard, but clinicians may benefit by unlimited availability and constant quality of acellular dermal matrix graft like the NovoMatrix, and furthermore by reduced surgery time and less adverse effects at the donor site. Aesthetic outcomes may also benefit. Patients will benefit due to shorter surgery times and the absence of donor site morbidity. The total costs can decrease, increase, or stay the same depending on several factors. Thank you so much again for staying with us for so long. Before we get to the end, I would like to present a case to you. Linda had to go through a very demanding breast cancer therapy, and so we decided to avoid as much comorbidities as possible. This is the upper jaw before treatment, and this is the lower jaw before treatment. We did a backward planning and also tilted implants a little bit to take advantage of the residual bone. We tried to avoid periostal incisions by preparation of the superficial part of the mylohyoid muscles. And we utilized the cervical system to care for proper emergence profile. This is the molar profile. And on this picture you can see a guide for premolar profile. Implant placement was prosthodontically driven by a guide, which was delivered by the dental lab. This is how the NovoMatrix looks like when it is taken directly out of the box. It is already hydrated, but the manufacturer recommends to leave it for 2 minutes in a physiological saline solution. The matrix can be folded in order to even gain more tissue. In this picture you can see Mineros XP granules together with autologous bone, which was harvested out of the implant bed. Everything was mixed with blood concentrates in order to achieve a sticky configuration. The granules were covered with the matrix. On the right-hand side, the same approach was taken. You can see that we utilized healing caps as a tenting screw to lift up the flap in order to decrease pressure on the augmented area. Primary wound closure was achieved by deep horizontal mattress sutures and crestal interlocking continuous sutures. This is the post-op X-ray. I had to rework 2 of the healing caps, which were not located in their target position, but it was easy. Wound healing was uneventful. This is a clinical aspect after 6 days, after 3 weeks, and after 1 month. The first 6 mm healing cap could be seen on the right side. And after 7 weeks, the others followed. After 2 months, we started to work on the emergence profile, as you can see here. and after another 3 weeks, the tissue started to get more and more mature, which can be seen in the photographs from the lateral sides. When you take a deeper look, you can already imagine the gain of vertical soft tissue height. After 3 months from the very beginning, a semi-permanent prosthodontic solution was delivered by the lab. I often like to use an intermediate structure. In this system, it is called a comfort abutment. It allows me not to get back on the implant level, but to stay on a prosthodontic level, which is very convenient for the patient. This is the situation after screwing the prosthodontic restorations on the comfort abutments and after closing the screw channels with sterile Teflon tape and a composite. On the left side you can see stable conditions with the fixed mucosa. And this is the opposite side with the same result. I would like to complete this case with the corresponding histological findings. After 8 weeks of healing, you can see a very natural appearance of the augmented area in comparison to tissue samples of non-augmented individuals. And also by zooming into the images, a very natural appearance of the augmented area appears. When you take a closer look at the zone where the residual membrane can be expected, you will find little areas of infiltrates which may be interpreted as a kind of soft tissue remodeling. Probably parts of the residual membrane can be seen on the right-hand side and are marked with black arrows. And once again, these residual membrane parts look very natural in comparison to the surrounding tissue. And finally, my conclusions for this case are that the patient's acceptance to this procedure was very good. Histologically, we did not find any signs of anomalies and the soft tissue thickening was successful. But the observation period of this case is short and further investigations are needed. The last point on the agenda is a discussion of our topics, but before we start with it, let me say thank you very much for your kind attention. I appreciate it a lot. Feel free to email me. My email address is andreas.van.orten@icloud.com. Thank you very much.